dear professors and colleagues. I'm very honored to be with you today. Today I'm going to present a topic about the role of dual energy CT, dual layer detector spectral CT in evaluating focal pancreatic lesions. We know that multi-detector CT is the gold standard imaging modality for evaluating pancreatic lesions. And despite the use of optimal multiphasic protocols and optimizing acquisition times, still pancreatic imaging remains to be challenging. And these challenges are related to the detection of small early stage pancreatic cancer, characterizing subtle features within cystic lesions that indicate malignancy, or localizing small-sized neuroendocrine tumors. These challenges could be attributed to either the inherent limited soft tissue contrast of multi-detector CT or the limited difference in vascularity between pathologic lesions and pancreatic parenchyma. So if the contrast between the lesions and the pancreatic parenchyma could be improved, we would expect an improved performance of CT in evaluating pancreatic lesions. So how can dual energy CT help? It's a relatively novel technology that has evolved over the past several years and been introduced in clinical practice. It allows simultaneous acquisition of low and high energy data sets, either by using two different X-ray energy spectra or by spectral separation at the detector level. And the basic principle upon which the technique was founded is that attenuation of X-ray photons differ for different materials at different X-ray energies. For the single polyenergetic spectrum used in CT, there is substantial overlap in the attenuation of tissues because they're made up of substances of similar atomic number. So there is uncertainty in their differentiation. And since the CT numbers depend on energy, so the use of two energy peaks, a low and a high peak, would help differentiation. For the energy range used in CT diagnostics, the attenuation of photons is mainly by two predominant phenomena, the photoelectric effect and Compton scattering. The measured attenuation is the sum of both, and the relative amount of each depends on the energy of the incident photon as well as the atomic number of the absorber. Compton scattering varies little with the change of energy, whereas the photoelectric effect is highly energy dependent. Also, photoelectric effect dominates in the use of absorbers of high atomic number, such as iodine, which is the contrast agent that is used in CT. And also it increases when the energy of the X-ray photon is just above the inner shell binding energy of the absorber, which is 33.2 keV for iodine. And so the use of low energy photons that are close to the K-edge of iodine would result in increased photoelectric effect and high photon absorption, and thus increase in enhancement and in the CT numbers of tissues that have taken up iodine compared to the surrounding tissues. And they will be easily delineated and more conspicuous. The dual energy technologies present are either emission-based, such as dual source CT, twin beam CT, rapid kilovolt switching technique, or dual spin CT, or detection-based, such as the dual layer CT, where the lower energy photons are detected at the upper layer detector and the higher energy photons at the lower detector. The data from both layers are integrated and used for each tank to produce both conventional images that are similar to the images produced from conventional CT and spectral-based images. These spectral-based images are either energy-specific images, which is the mono-E images, which range from very low 40 keV to 200 keV, and the choice of the image of the energy depends on the diagnostic task, or material density images, such as iodine images, virtual non-contrast images, and effective atomic number images. Now I present some cases from our work. A pancreatic ductal adenocarcinoma in a 67-year-old man. On a conventional single-phase venous phase image, the lesion appears to be ill-defined and slightly hypoattenuating and not easily differentiated from the surrounding pancreas, and it's seen reaching the medial border of the duodenum. However, on the spectral images, the lesion is much more conspicuous and it could be easily demarcated from the normally enhancing surrounding pancreas, and the internal details of the lesion with the encasement of gastroduodenal artery and the internal necrosis are much more conspicuous. Another is an insulinoma in a 50-year-old man. On a single venous phase conventional image, we can see that the lesion is sub-centimeter tiny, hypoattenuating with a rim that is barely perceived as iso to slightly hyper-enhancing. However, on the spectral images, the low KEV iodine overlay and Z-effective images, the surrounding hyper-enhancing rim is much more conspicuous, which aided the diagnosis. Another is neuroendocrine tumor in a 47-year-old woman. On the conventional venous phase image, the lesion cannot be differentiated from the surrounding pancreas. It is normally of the same attenuation. It could be identified by the distortion of the pancreatic border it is causing. However, on the Z-effective images, the lesion is much more conspicuous and it could be demarcated from the normal parenchyma. Another lesion was a cystic lesion. On the conventional images, we can see that the lesion is macrolobulatic with thin internal septi. There is no communication with the nearby pancreatic duct. And at a lower axial cut, there are mural-related densities that appeared that would raise the suspicion of malignancy rather than less likely internal cyst debris or content. On the coronal cuts, there is intermediate contrast between the fluid content and the peripheral density. And on the low KEV, 40 KEV mono E image, there is accentuated contrast between the peripheral component and the cyst fluid, which indicates iodine uptake. And this was confirmed by the iodine density image through the quantification of the iodine of this peripheral solid nodule, in comparison to the cyst fluid, which was devoid of iodine. Also, a spectral plot was produced, and the cystic content showed a flat curve. The peripheral solid nodule showed an intermediate curve, yet it was lower than that of the normal parenchyma. It denoted the uptake of iodine, and it confirmed the solid lesion, the solid nature of this lesion, through only a single phase, a venous phase, without the need of any pre-contrast phase. This is a metastasizing neuroendocrine tumor. On the conventional venous phase image, the lesion is very subtle and it could be barely delineated. And we can see multiple metastatic lesions in the liver. However, on the spectral images, the lesion is much more conspicuous at the tail of the pancreas. And there are some lesions that we can see undoubtedly on the spectral images. However, they could be barely perceived on the conventional image. And therefore, we can finally conclude that the dual-layer spectral CT deconstructions, namely the 40 KEV mono-E, the iodine and Z-effective images, provide an added value over conventional CT in evaluation of focal pancreatic lesions, and that the improved detectability of dual-layer CT could restrict our need for multiple CT imaging phases or the need for additional imaging modalities, thus reducing costs and radiation exposure. Thank you.
Thank you very much, Professor Nada Kayal. Our next speaker is Dr. Nada Saad. He's going to give us a talk about imaging in bariatric surgery, a guide to complication.